all. And I believe questions as you go. If you have
Absolutely.
questions.
Absolutely.
Perfect. Thank you.
Awesome. Thank you, Aaron. So thanks for coming. Can you guys hear me? Is the mic okay? I'm Marion Herring. I'm a sports medicine shoulder surgeon here at this office. I've been in Richmond about 15 years. I'm from North Carolina. I went to Washington Lee, UNC, did some time at UNC, and then did my fellowship at Duke, so I've got some mixed blue blood in there. My daughter just graduated from UNC, so if you're asking who I cheer for, Tar Heels. We're going to talk about treatment of shoulder issues. We're going to focus on the rotator cuff, and as we're going to do some shoulder replacement stuff after that. If you have questions, let me know. Got it? Next. So you can't talk about the shoulder without talking about anatomy. Our whole job in shoulder treatment and surgery is to recreate anatomy. And I think we're getting pretty good at that. But our job is to try to help you maintain your anatomy and to recreate anatomy if we're doing reconstruction type stuff. So I'm going to call your attention to this picture over here. The shoulder anatomy, the humerus bone is his arm that hangs down by your side. The socket part is the scapula. We call it the glenoid, okay? Chromium sits up top, clavicle hooks in there, but that's the bony construct of the shoulder. I'll call your attention. We're going to talk a lot about this. The rotator cuff's on the outside. There's a small bursa, but the bony anatomy is what provides the foundation of the shoulder. The bone is off, it's not going to function very well. Next slide. The next layer out is the cartilage or the labrum, okay? If you look at the shoulder construct, it's very similar to a golf ball on a golf tee. It makes no sense why it should work, okay? Because the glenoid component is very, very small, and the humerus component is an oversized golf ball. What in the world holds it in place? What holds it in place is the labrum, which is basically like your nose or your ear, right? It's that consistency. The labrum deepens the socket to help hold it in place. And then the shoulder capsule or the lining attaches to that, and that helps the stability of the shoulder. We're not going to focus on that tonight, really, because that's in dislocations, labral tears, and stuff like that. That's probably a different talk. Next slide. The focus will be mainly on the rotator cuff, not cup, rotator cuff. It's 4 muscles. The subscapularis is a muscle in the front. It runs in the front and helps you pull your arm across your chest. The supraspinatus comes across the top. That's probably 90% of the tears we see. And the supraspinatus is what helps you initiate and raise your arm overhead. And then you have your muscles in the back that help rotate your shoulder out. The subscapularis in the front and the muscles in the back help pull the shoulder down and in, help holding it in the socket. If there's dysfunction of the rotator cuff, you lose dynamic stability of the shoulder, and then you're kind of down that bad pathway. So the shoulder blade is something we preach on all the time. The shoulder joint itself with the glenoid and the replacement and the rotator cuff are the sexier things. Nobody wants to talk about the shoulder blade, okay? If your posture is bad, it doesn't matter how good your shoulder is, it's not going to function very well. So when your mom told you to sit up straight and pull your shoulders back, she was talking about your shoulder, the stability of your shoulder. So when I talk to patients in clinic, I tell them the shoulder's like a beach house. The shoulder blade are the pylons that go in the sand. And the shoulder that everybody likes is a fancy house. If those pylons are weak, the first wave that comes in, your shoulder's gone. So think about your shoulder blade. Think about sitting up straight. When you focus with physical therapy, that should be the focus. Because if you have a good solid foundation, your house can be less attractive or less weak, right? So think about the shoulder blade. Next. So when you come in and you have a shoulder injury, it's our job to get a history and do a physical exam. So you can expect that, right? So is it an acute injury? Did you fall off a ladder and all of a sudden you have no shoulder function? Or has this been 65 years of slow onset of shoulder pain? That matters, right? Are you doing repetitive motion? Are you in the pickleball craze, right? Are you playing pickleball eight days a week and now your shoulder's hurting? Are you lifting? Does your work aggravate it? So are there repetitive motions that make it work? And these are usually hobbies, work. The main thing that usually drives people in to a shoulder clinic is nighttime pain. Because if you ain't sleeping, you're miserable, right? People can tolerate daytime pain, but if you're having nighttime pain, you're like, or your significant other just sleeping right by said, you got to go see a doctor because you're driving me crazy, right? So nighttime pain is a big issue. That can be arthritis, that can be rotator cuff, but nighttime pain is the number one complaint that people say. That's why they come into the office. If you have pain that you think is shoulder pain, and you come in and say, I have shoulder pain, we send you to our neck guy, right? Because if you say I have shoulder pain here, that's not coming from your shoulder, that's from your neck, okay? If you say I have shoulder pain that radiates all the way into my thumb, that's likely your neck, right? So true shoulder pain is usually referred to the lateral side of your arm. That's where arthritis pain is, and that's where rotator cuff pain is. So if you're having pain generated from your neck, you're going to say, I have pain here. You say, I have pain in my shoulder, rotator cuff pain, I have pain here. If you have pain that radiates into your thumb, we're going to have you see our neck person. Okay? Next. We do an exam. We look at your skin. What we're looking for are deformities, scars. Have you had an unfortunate surgery before, right? Does that scar make sense? Do you have atrophy of the muscle? And sometimes it's hard to tell what's going on with the skin, okay? So when we inspect, we look at the skin, we watch you move your shoulder, we watch you take your shirt off, and see how you move. Next. We look at your range of motion, passive and active. And what that means, whoever you're seeing should take your arm through a range of motion to see if it moves freely. If it moves freely in the passive range of motion, we look at active range of motion. Can you raise your arm up? Can you rotate your arm down? All those things can kind of help us decide on what the diagnosis is. Next. We will look at the rotator cuff exam. We've talked about the rotator cuff. There's all different ways to look at the strength. We can look at the supraspinatus by having you push up. We can look at the rotation in the back by having you push out. And look at the subscap. You can push your hand off the back. But there's specific tests we look at for specific tendons and muscles. So that's why you say it hurts, and we still have to examine you because we got to try to figure out what's hurting. Okay, next. You can expect some imaging, right? So usually to properly evaluate a shoulder injury, we get x-rays. We get 3 or 4 views specifically designed to look at the shoulder joint. And you say, well, I know it's a rotator cuff. You don't need x-rays. Well, yeah, you do, because there's spurs and there's arthritis and there's other things that can be hiding in there. And also, you're not getting a scan without an MRI scan, without an x-ray, because your insurance company won't let you. So usually we get an x-ray. We're looking for arthritis and bone spurs and stuff like that. Got it? Please.
So you don't have ultrasound on there?
Yep, I do not. Go ahead.
Do you use that as one of your imaging?
I do not usually, and why that's a newer imaging technique, and it's really a first look. You can use ultrasound to look for a rotator cuff, but it does not help me in preoperative planning, okay? So, and I just haven't used ultrasound. I don't use ultrasound for injections. I've been doing injections forever and ever. There's some guys that use ultrasound to follow their rotator cuffs and repairs, and there's nothing wrong with that, okay? So we use x-ray at first pass. If we think you have a rotator cuff and you failed physical therapy and you've had injections and you've not gotten better, sometimes you get a scan. You get an MRI scan, okay? So what that means, here's the socket, here's the humerus, and unfortunately, this is a rotator cuff tendon, and it belongs way over there. So we can look at that MRI scan, and we can determine, is it a tear or not, how big that tear is, and if it's fixable or not. Because if that tendon is retracted a certain amount, or if there's atrophy of the muscle there, or the tendon quality ain't so good, it may not be fixable. So we use the MRI scan to tell us if it's fixable. Good.
How current the X-ray should be? If you had had one done, let's say 18 months ago,
That's
are
fine.
you going to do another one?
No, I'm not going to do another one unless you've had a fall or trauma or something like that.
So like 2 years, 3 years?
It's fine. Unless you've had significant change, you shouldn't need another X-ray.
Gotcha.
Okay?
Is that one fixable?
That one is not fixable. And we can talk about the specifics. So the humeral head is no longer in the joint. So when you have lost that stabilizing force of those tendons that pull down, to think you can go in there and take this tendon and seat it back down ain't going to work. And there's other images of this patient that shows atrophy of the muscle. So if you have atrophy of the muscle and you're retracted back to the rim and your humeral head is up, there's no chance you're fixing that. Okay? In my younger, not so smart days, I thought I could fix those. And I actually made patients worse.
So what is that, replacement?
That's a replacement. And that's the next part of the talk. Hang on just a second.
Are most shoulder replacements due to arthritis?
We'll talk about that. No. So we're going to cover a lot of shoulder replacements, but yes, most shoulder replacements are due to arthritis.
It's more radiologic question in terms of radiation exposure for the X-ray. What are we talking about?
So not much here, a little more here. Okay? I don't know the amounts. You do not come out of the machine glowing, so I'm not sure. I don't mean that, but I just usually we use that X-ray. We use an MRI scan if we're worried about a soft tissue injury, and we get CT scans if we're worried mainly about arthritis, planning for shoulder replacement. Okay, and you can see from this image, this golf tee, golf ball analogy. You see that the head is shifted out the back. It's bone on bone there. That's just bad arthritis. So the point for you guys is just know you've got an X-ray we have to look at. You may or may not have an MRI scan, and then we use CT scan mainly for preoperative for shoulder replacement surgery. Okay, next. So diagnosis in the shoulder world is usually age-related, right? So if you're less than the age of 40, which I'm way past that, it's usually labral tears or instability, meaning your shoulder is not staying in the joint, or dislocation, right? There are some younger than 40 patients that have rotator cuff tears. Those are folks who have done too much overhead sports, thrown, and the rotator cuff, unfortunately, is compromised at a very young age. Okay? Usually from 40 to forever. This is impingement, and we'll talk about that, but that's where the rotator cuff starts to break down. Okay? And then arthritis is listed as greater than 70, but we're actually seeing arthritis at a much younger age. Okay? But we can break the diagnosis. You guys can break the diagnosis down into we can break the diagnosis down into instability, means the shoulder's not staying in place, rotator cuff, which we're going to talk a lot about, and arthritis of the joint. Okay? Next. So rotator cuff will be the focus, okay? So if you think you have a rotator cuff, one of those four tendons are torn, usually it's an acute tear, meaning you fell off a ladder, now you can't raise your arm, or slow onset, you've had pain, now you have nighttime pain. It's usually pain, weakness, and decreased overhead use. You say, I'm fine down here, but every time I try to change a light bulb, I can't work overhead. That's usually rotator cuff pain. Okay? So, as we talked about, that pain is the referred pain where you sense it is usually down the front part of your arm. I mean, the outside part of your arm. If you say you have pain here, it's probably in your neck. If you say you have pain in the front, that's usually your biceps. But that can be shoulder related. But lateral arm pain is where the brain perceives rotator cuff pain. Okay? The other symptom we see is early fatigue. People say, I paint or I do stuff, and then now my arm gets so fatigued so fast that can be rotator cuff weakness, rotator cuff inflammation, or a tear. Got it? Nighttime pain. Again, when you come in and your ears are red, what that means is your significant other is saying, you got to get to the doctor because I'm tired of you complaining at night. Okay? So, nighttime pain is the main thing that brings people in. So, anatomy. Again, when you have rotator cuff disease, when you have rotator cuff injury, the main focus has to be restore normal anatomy. Okay? So, shoulder blade, humerus, the supraspinatus, again, that's the most commonly affected tendon, comes right across the top, helps you raise your arm up, helps stabilize your shoulder, and this fluid-filled sac called a bursa sits right on top, and its job is to protect the rotator cuff from the acromion. And people say I have bone spurs, right? Usually that means you have a small bone spur here that digs into that bursa. If you have inflammation of the bursa, next slide, simply put, you got bursitis. So that bursa gets inflamed, and then that comes from repetitive use. Okay? Now that bursitis hangs out around, it hangs out, you get worse and worse, and the next step is you have tendonitis. So orthopedics has to be very easy, right? So the progression is bursitis, or inflammation of the bursa, tendonitis, which is inflammation of the tendon, and then that tendon starts to break down. If the pain continues, the next step is a rotator cuff tear. Okay? So the bursa gets inflamed, the tendon gets inflamed, and now you start to get these micro tears, and all of a sudden you try to raise something up, and all of a sudden that tendon is torn. Now you're in the office, right? You have a rotator cuff tear. The most common tear is that supraspinatus. The most common complaint is nighttime pain. And the other common complaint is I can't use my arm here. Got me? Next slide. So now what do? Just because you have a rotator cuff does not mean we're racing off to the operating room, right? So if it's a partial tear or if it's not very retracted, there are some conservative means, okay? Usually 6 weeks to 3 months. You can take non-steroidals as long as it doesn't hurt your gut and cause ulcers, okay? Rest. People hate to rest. You can modify your activity. You can change what you're doing lifting. You can, on pickleball, you can switch hands if you're coordinated enough. But you have to, if you're treating the inflammation, the bursitis and tendonitis, you cannot keep stressing the tendon over and over and over because you're chasing your tail, right? So rest, activity modification, and insets, okay? The most important thing, right? The most important thing are the therapeutic exercises. And I'm a true believer you can't download from Google exercises and do them right, okay? We send you to our therapist. They do a fantastic job making sure you do them correctly. And it might just be, might be 1 or 2 visits, but it's worth learning how to do it correctly. Because if you Google exercises and you're trying to do these band exercises, you're going to get worse. Because likely your shoulder blade posture is not great, you're not doing it correctly, and you'll overload the tendon. So we highly encourage people to go to therapy and learn how to do them correctly, and that should be part of your maintenance exercise, right? If you have a rotator cuff dysfunction and you go learn your exercises, that's long-term health. Super important. Got me? So therapeutic exercises are key to getting better. Now, I do use steroid injections. What's a steroid injection? A steroid injection is a cortisone. It's like putting Motrin or lead right in that space. Its only job is to decrease the inflammation. Are they effective? Yes, they're very effective. Can they be overused? Yes. So we tell people 3 injections a year. That's safe, but you should not have 3 injections because it can soften the bone and soften the tendon. So use therapeutically, they can allow you to do your exercises. And again, going to therapy is the most important thing as the conservative treatment. Go ahead.
How long should a injection last? You said 3 times a year, not every 3 months or last 3 months?
You can't answer that question because if you put an injection in there and don't do the exercise, waste your time. So if you put an injection there, some studies will say that injection should stay in there about 6 weeks. But our job is to put the injection in there that lowers the inflammation, that then allows you to do the exercises that keeps the inflammation from coming back. So some people get 6 months out of it. I had an old professor at Duke who used to say, if they didn't do the exercises, the first injection should last you about 6 months. The second injection should last you about 6 weeks. And the third injection should last you about 6 hours because they become less and less effective. But again, we should be using those injections to allow you to do the exercises. Make sense? Please.
What are your thoughts on PRP injections for inflammation?
I think if you have extra income, you're much better off investing in the market. So insurance doesn't pay for PRP, okay? And so it has never been shown to be effective in the shoulder, okay? It's effective in Achilles tendonitis. It can be effective in the elbow. There's some studies that say it's effective in the knee, but I've never, and I read about shoulders all the time. I've never seen a study that says PRP is effective in the shoulder. And you can find people, they'll put PRP wherever you want to put PRP. But again, insurance doesn't pay for it. And here in this office, it's $750 cash. So I tell people that ask about it, if you want me to put PRP in there, I'm happy to do that. But you're much better off putting $750 on something that's going to make you some money, because it ain't going to help you. Okay?
What is PRP?
So platelet-rich plasma, we draw blood, we spin it down, we get the growth factors out there, the magic solution, and they stick it in there. Okay? It can be effective in certain areas. I've not pushed it in the shoulder, that in stem cells, because I've not seen the effect. And I'd have a hard time telling you to spend $750 when in 4 months you're going to be saying, I feel exactly the same. Okay? So we use injections diagnostically and then therapeutically. What does that mean? So if I'm convinced you have pain in this subacromial space, I'm going to put that injection in there, and if you say, I got no better, my diagnosis is wrong. Okay? So I use it. So if I put that injection in there and you're like, woohoo, I feel great, that lidocaine that's part of that injection can be a diagnostic test where we know that pain's coming from that point. Okay? If I inject your AC joint, which is where the clavicle hits, and you get no better, my diagnosis is wrong. Okay? So we use that as a diagnostic injection to help me define where the pain generator is. I also use it as a therapeutic injection, again, because it's an anti-inflammatory effect. In my opinion, take it for what it's worth, it's only good in association with therapy exercises, appropriate therapy-driven physical therapy, making sure you do it correctly, exercises. Please.
I've had several injections, and some doctors put them in the front, some go in the back.
Sure.
What determines the front or the back?
Well, so for me, if I'm going to inject your joint, your glenohumeral joint, I'm going to go from the front because I know I've got a 95% chance of putting it in the right spot. If I'm going to inject the subacromial space, I'm going to go in the back. Okay? So just because you have an MRI scan that says you have a tear does not mean we're going to the operating room. Okay? There are some very good studies out there, and these are in asymptomatic folks. Okay? If you're over the age of 60, up to 28% can have complete rotator cuff tears and are asymptomatic. And asymptomatic means they're playing pickleball, they're doing whatever they want. Okay? So just because your MRI scan says you have a rotator cuff tear does not mean we're racing you off to the operating room. Okay? So just keep that in mind. I have people every day that come in and say, I have an MRI scan, I'm having no symptoms at all, I can function exactly like I want to function, I want you to fix it. I was like, I can make you worse. I can go in and operate on you, and you can develop some scar tissue, and I can make you worse. Or you can keep doing your physical therapy, and we'll see how you do. Okay? So if it's a partial tear, Dave, and you have pain, and you're doing your exercises, we tell you to do your exercise. We use injections. If it's a full tear that's retracted, that's a different ballgame. Okay? But if you have a partial tear or one that's not retracted, and you're asymptomatic, run from surgery. Because we can absolutely make you worse. Okay? Work on your platforms that go in the ocean, right? Work on your shoulder blade. Make your shoulder blade strong. You'll get better. Next. Now, when do we operate? Pain, functional deficits not resolved with conservative treatment. Okay? So if you've had therapy, you've had injections, and you're not better, and you can't function, and your ears are red because your significant other is yanking your ears to get treated, right? We start talking about surgical indications for rotator cuff. Okay? Nighttime pain. Again, you're not sleeping, you're not getting better. So nighttime pain and pain and functional deficits not resolved with conservative measures usually ends up with surgery. The only flip side of that is if you have acute loss of function, you've fallen, and all of a sudden you can't raise your arm up, that's an acute rotator cuff tear. That needs to get fixed within the first 6 to 8 weeks to give you the best outcome. So there's two different animals there. There's that slow onset of pain. We're doing conservative measures. We're doing good physical therapy. If that fails, you get surgery. The other option is if you fall and you have acute loss of function, get it checked. Because if you come in at 6 months, 8 months, 10 months, a year, and you've had a tear that you say, well, I fell off a ladder 6 months ago and I've been doing this for 6 months, I'm going to have a sad story because likely that's not a fixable thing. And so keep in mind, you have acute injuries, need to be fixed right away, and you have these slow onset that we kind of drag it out a little bit and make you suffer. Okay? Next. So there are size of tendons. The reason this is so important is usually the outcome is based on the size of the tear. So this is assuming you've failed conservative measures. This is assuming you've had an acute tear, and we're talking about surgery, okay? The MRI scan says it's a small 1 centimeter, 1 tendon tear. Those do very, very well. You get back functioning 3 or 4 months, awesome. If it's a medium-sized tear, it takes a little bit longer to get back. If it's a massive tear, I hate the word massive. I have patients say that they're crying because they have a massive tear. All massive means is 2 of the 4 tendons are torn, right? Don't think about massive being massive. So what I need you to think about is massive tear is a 2-tendon tear. The reason that's important is that takes a little bit longer to fix. It takes a lot longer for our physical therapist to get you back to 100%. Okay? Muscle atrophy and tendon and bone quality are the most important things we look at on the MRI scan because that tells us, is it fixable? Is it not? Partially fixable. Okay? Next. Now, we fix a ton of rotator cuffs. A lot of rotator cuffs. And we do it really the same way over and over and over. So we you can see here, this is the humerus bone. This is a massive rotator cuff tear. This tendon belongs down to there. So you're looking down the pipe. Okay, so this tendon, this was an acute injury. This patient fell off a ladder. Watch out for ladders. And this tendon has torn away from the bone. So we'll clean this back to nice bleeding bone. That's where the PRP comes from, the healing potential, right? We put anchors in the bone, all different types of anchors. And the anchors are attached to suture. We bring the suture to the tendon. This is before, this is after. Okay? So our job is to take this mess. We create some healing potential by getting down the bleeding bone. We put these anchors in the bone, and we pull this tendon right back down to bone. If we're stable to that pull, then we start your physical therapy. Now, your physical therapy depends on small, medium, large tear, because it matters, right? If it's a small tear, we let our therapies have at you at about 2 or 3 weeks. If it's a larger tear, we hold you for 4 weeks to give that tendon a chance to heal. Okay? You got to behave yourself. You got to stay in the sling, but this is just the way we fix it. This is a tear. This is where it came from. You use the anchors. This is after.
Is all of that then permanent?
That's a good question. So the anchors that we're using now are a special plastic that resorbs over time. Sutures stay there. Okay? And the analogy that I agree with the most is this is like rebar, right? So rebar inside the tendon. If we go back and do total shoulders, and if you've had surgery before, that suture's still there. Okay?
So you have some foreign materials that's go in the body and your body kind of gets adjusted to it?
Suture, yes, sir. Next. Okay? So if we feel like you would benefit from a partial repair, meaning one of the tendons is repairable, that's a possibility. Because as we talked about, that subscapularis muscle in the front and the infraspinatus in the back, if those are functioning well, usually your shoulder can stay pretty well stable, right? So sometimes we'll say, well, we can't fix it all, but sometimes we can do a partial repair and that can help. Okay? There's places we can augment the repair. We're using these devices that are made up of dermis, skin, where we can reinforce a repair by stitching that dermis on demand there, and that can reinforce the repair. There's some people that are doing augments that aren't functioning very well, because if that tendon's gone, it's gone. If we can get the tendon back down to bone, sometimes we'll augment that repair, and that can help the outcome. So go ahead, sorry.
So do you know that before surgery as to?
Yes, yes, but because when we look at the MRI scan, again, we're looking at size of the tear, retraction, and then what the tendon quality is. If I'm convinced the tendon quality is not great, we're talking about this before you ever go to sleep. Okay? Next. So questions on rotator cuff. Anatomy is key. The MRI scan is key. Small, medium, and large tears do not act the same, and therapy is crucial. Please.
I have a question. You talked about anatomy of it. My younger brother went in for rotator cuff surgery, and when they opened him up, they said his rotator cuff was backwards. He was born that way. So would that show up on tests
Yes.
today, like MRIs? Because this was like 15, 20 years ago.
Yep.
So,
Yep.
okay.
That would show up on a scan. And our imaging now is so exact. We've got a fantastic picture of what we're going in and look for. The only thing the scan is not great looking at is the biceps. So a lot of times we go in to fix rotator cuff and the biceps is torn as well. It doesn't really affect things. It doesn't affect the outcome. But yes.
Would you leave the bicep unattached or torn and not repair that when you were in doing the supraspinatus?
So I'm a bicep predator, okay? And the reason I say that is I have been fooled more times by leaving a bicep that looked angry than taking down and fixing it and taking it out. So if there's any question that long head of the biceps in the joint is damaged, I fix it.
If there is a bad tear and PT hasn't really helped, I sleep okay, but is there a reason to try steroid injections?
Sure. Because if you try a steroid injection, a lot of times it can lower the inflammation enough where then you can do more adequate therapy. But there's two different complaints there, right? If it's a pain issue, steroid can help. If it's a functional issue and it's weakness, steroid ain't going to help that. Okay?
Talk a little bit about the bone spur.
Yep.
You said earlier about it's impacting the bursa.
Sure.
Does it also affect or can it cut any of the tendon or?
Yep, that's a great point. So can you go?
What else bad can a
Yep.
bone spur do?
Can you back to that animated drawing? Keep going. All right, okay, that's good. So when you talk about bone spurs in the shoulder, usually they happen to two different places. Okay, so usually when we talk about bone spurs, it's off the acromion bone. Okay, and unfortunately, that's right where the tendon inserts. So if you're a guy who does a lot of work overhead, and that spur has developed over time, it digs into the bursa and digs into the tendon. It frays the tendon gets worse and worse and worse. So that's where impingement comes from, because the humerus impinges against the acromion, causing the chaos in there.
So can it eventually cut the tendon?
It does cut the tendon, because that tendon gets weaker. The tendon gets weaker. And usually, it's not the spur that cuts the tendon, it's the spur that makes the tendon weaker, and then you reach out to grab the milk out of the refrigerator, and bink, it tears. It would not have torn from that normal motion unless that tendon has made unless that spur has made that tendon weaker.
Does that complete tear then pull the tendon all the way back?
It does. Because once it's torn completely, whether it's an acute injury or not, it retracts off the bone. Now, the other problem, it's a good question, the other problem is the clavicle bone, your collarbone, it comes over and meets the acromion right here. Okay? And it's more common in guys than girls, but you can have arthritis in this AC joint, and that can develop a spur. Those spurs are much more problematic because that spur is going to dig into the muscle tendon junction, and it can tear the muscle tendon junction. Those are non-fixable because you can't have a tear here and pull it back over to here, right? So when we see people that have AC joint arthritis and they have a spur and they're having severe edema in this area, we're usually pretty aggressive about going there and flatten those spurs out. Because if that spur goes on to cause a muscle tendon tear, we have a very sad clinic appointment. But I can't fix it.
Are the spurs graded in some way?
Sure.
Yeah.
1, 2, and 3. 1 is a small bump. 2 is a larger bump. 3 is a sharp spur. 3 is bad. Did I answer your question?
Yes.
Okay. Go forward. Any other? Go ahead. Hang on just a second.
You haven't really talked about infraspinatus.
Yeah.
What type of surgery would you do for
It's
that?
the same. It's the same. So all the rotator cuff tendons, it's an arthroscopic repair. We're putting in those anchors and stitching it back down. It is uncommon to have an isolated infraspinatus tear without trauma. And the reason is there's no spur back there. We do see infraspinatus tears that people do a lot of backhand stuff. We do see infraspinatus tears with people that fall down, but it's uncommon in folks that have slow onset of pain. But the infraspinatus repair is exactly the same. It's putting in anchors and stitching that tendon back down. There's one more question in the back, I think.
So I knew when I couldn't sleep at night, I had an issue.
Yeah.
So
Are your ears red? No, just kidding.
it was worse than that.
Yeah.
So I had to start with PT.
Yeah.
So I'm asking one of your fellow surgeons, I'm like, oh, I don't understand this. I've got to get an MRI, or I want an MRI to see what's going on,
Mm-hmm.
but I got to do the PT first.
Yes.
I've been to that for 5 weeks.
Yep.
Scheduled the MRI. Now
Yep.
the question becomes, say it's a small tear.
Yep.
And I go on about my business, I'm doing my exercises. What keeps that small tear from becoming a more substantial tear, which would probably wind up with surgery at some point down the road?
Nothing. Because if you have a small tear, it will progress. Now, our physical therapists are very skilled at showing you strengthening exercises that can offload that. They're working on your shoulder blade strength. They're working on the other tendons that are normal. But we do know there's great studies out there that say smaller tears progress to larger tears, right? So again, if you do your therapy and you're feeling great and you can do whatever you want to do, leave it alone, right? If you're noticing increasing weakness and increasing pain, that means the tear is getting worse. You got to get it evaluated, right? And a tear that goes from a 1 centimeter tear to a 3 centimeter tear, big deal. It's one more anchor, right? So if we think that people can be asymptomatic with a less than 1 centimeter tear, we always try conservative measures first, unless it's an acute injury. Make sense? Okay.
But as far as the tear is concerned, I mean, if you leave it alone, will that tear repair itself?
No, sir. There is no blood supply in that area. It's not going to repair itself, but sometimes it can become asymptomatic. If you do the exercises around it, sometimes it can become asymptomatic. But especially the ones that are underneath tears, there's no blood supply there. And if you have a spur there, that spur is going to keep digging in. It doesn't heal, but it can become asymptomatic for sure.
If you have arthritis in your shoulder, it's bone on bone, is therapy, or can therapy help?
We're going to talk about that a little bit, but in my opinion, therapy can always help. So sometimes it requires a trial. The problem is these therapists that are here can tell you, is it can make you worse. Because if you're bone on bone, like this person, and your shoulder is subluxed out the back, and I send you to therapy to work on your motion, you're grinding that down, it's a Rice Krispie treat, right? It's snap, crackle, and pop, and I've now made you worse. But I'm a true believer in physical therapy where strengthening the muscles can always help. And if, unfortunately, you have to do a shoulder replacement, any therapy strengthening you do before that is always helpful.
What
It has to do with tendon size and tendon quality. Okay, so it has to do with surgeon preference, or where we put anchors and that kind of stuff. So for me, I'll average 2, sometimes 3. If it's a massive tear, it can go to 3 or 4, but it has to do with the size.
And you literally pull the tendon back over?
Yes, sir.
Onto the humerus?
Right, we're recreating anatomy. So we take that tendon that's torn loose, we're creating a bleeding bed there to heal, and we're hopefully putting that tendon right back down where it goes. And we're much better arthroscopically, means a little poke hole surgery, seeing exactly where that tendon goes instead of just open it and trying to figure out where it goes.
So what's the term bleeding service?
Yeah, so when you do a rotator, get back to that rotator cuff picture, that one, okay? 1/4. So if you look at this tendon, it is torn away from this bone. But you have all this stuff here that's frayed tendon. So if I try to stitch this to this, there's no healing potential there, right? So what we do, we use these little burrs, and we'll burr down to bleeding bone, because that's where the healing potential comes from. And hopefully that bleeding bone will heal to native tendon. So you can't sew bad tendon to bad tendon.
Do you remove all of the old tendon there?
Here, yes.
Okay.
But we try to preserve as much of this tendon here because that preserves the length of the tendon. Okay? Other questions on rotator cuff? Please.
So say you got a partial tear, you got bone spurs, and you got arthritis.
Uh-huh.
You do the physical therapy, and during the day, everything's fine,
Uh-huh.
until I roll over at night.
Yep. So we try injections because a lot of times that doesn't help. So what we do, it depends on how bad your arthritis is and how bad your rotator cuff is. If you have minimal arthritis and we think your nighttime pain is mainly the rotator cuff or the spurs, we can go in there and flatten those spurs down, and sometimes that can make you better. If you have significant arthritis, we flatten those spurs down, you're going to come back in 4 months saying, I'm the same, right? So we have to make absolutely sure, and that's where we use those diagnostic injections. So if you're a guy who has bad nighttime pain, and you're a guy who has arthritis and a spur, I'm going to inject that subacromial space. If you get better, if you come back and say, wow, that was awesome, then I can tell you with pretty good predictability, I can go in there and take that burst out and flatten that spur down, and you're a lot better.
Do you reattach the partial tear at the same time?
If it's 50% or more, yes. If it's 50% or less, no, because your outcome's the same. And if we don't reattach it, your therapy and recovery is faster, right? And we know very well. If it's 50% or less, we can debride that area, and you do very well.
But isn't it a potential that it will continue to tear if you don't reattach?
Yes, yes.
So you're rolling the dice when you do that?
No, we don't roll the dice. So if it's 50% or less, there's no studies that show those tears progress, okay? And if we're taking out the spur, hopefully we're taking out the thing that's causing it to tear more and more. And if you do your shoulder blade exercises, and you sit up straight, and you do your cup exercises, you should be better. But again, 50% or more, we take that tendon down and fix it. Questions about rotator cuff stuff?
Does it help to do strengthening exercises before a rotator cuff?
Absolutely, 1,000% yes. Again, the exercise you do before only help you after.
Rotator cuff tendinitis
Mhm.
diagnosis, does that fall into arthritis category?
It does not, because tendinitis is inflammation of the tendon. Arthritis is destruction of the articular cartilage. They're two different diagnoses. Okay?
Are you going to speak any on recovery time following?
I sure am. Okay. Now, the next topic is arthritis. We'll talk about shoulder replacement a little bit. For those of you who came for rotator cuff, we'll see you later. Happy boating. For those of you who are here for arthritis, here we go. So shoulder arthritis usually presents with loss of motion, joints not moving very well, loss of function, you can't do your activities of daily living, and you'll come in saying, my shoulder's like a Rice Krispie treat. It pops and clicks and grinds, and I'm not happy. So when you wake up in the morning, you're like, oh boy, I can't move my shoulder. And as you move it more and more, it gets easier and easier. So morning stiffness, crepitation, clunking, have trouble with ADLs, loss of motion, okay? Pain, You can have pain with rest. You come in and say, look, I hurt all the time because you're bone on bone. That joint, when that cartilage gets broken down, hurt all the time. The positional pain at night, again, you hurt when you lay on that side. And you also got to be careful with the neck, because the neck can cause radicular arm pain. But when we're talking about arthritis, we're talking about loss of the articular cartilage, and you're basically bone rubbing on bone. Different than the rotator cuff. Next. So there are a lot of non-surgical treatments for arthritis. So just because you have arthritis, does not mean we're racing you off the operating room to do a shoulder replacement, okay? We educate you, hopefully, on the problem. So you understand this ain't an 18-year-old shoulder anymore, right? We can't make it perfect. This is not 18 years old. So our goal is to maximize your function, and hopefully you understand the limits, okay? Job modification, activity modification. Sometimes we have to modify what you do. NSAIDs, short term. We tell people you can take anti-inflammatories. You should be taking them for 7 to 10 days at a time and be off of them. It does you no good to take motion relief once or twice. It's not a pain medicine. You should be taking the anti-inflammatory like you take your antibiotic, right? The level has to get high enough, and you have to hold it there high enough to do any good at all. So if you're going to take a leave, you're going to take Motrin, you got to take it for 7 to 10 days straight to have an anti-inflammatory effect. Okay? You can take Tylenol. That's a pain medicine. You can take that occasionally. If you're taking Motrin leave once, skip a couple of days, and take another, you might as well take jelly beans because it ain't going to work. Okay? Now, glucosamine, chondroitin sulfate, it's like bald man, eating hair. Because you can't take broken up cartilage and expect it to grow cartilage. You can't. There's no way. There are people that swear by it. But scientifically, it's like bald man eating hair. Okay? So if you want to try to grow, sorry, Brandon. So if you want to try to grow cartilage, help us. You get a Nobel Peace Prize. Because we've never been able to grow cartilage, right? So if you lost cartilage, that's a terminal event, right? We can't fix that. And you can take anti-inflammatories, 7 to 10 days, like we talked about. But I'm not a big believer in glucose and chondroitin sulfate. You take that for what it's worth. We do use injections in the joint. That's the injections from the front. We put those injections in the joint. That glenohumeral injection, the anti-inflammatory, sometimes can lower the inflammation to then allow our physical therapists to do their work. If you come in saying, look, I hurt you bad, there's no way I'm doing therapy, we're going to try to help you do therapy. We're going to put an injection in the joint. And that's when we're talking about you can only have 3 injections in a year. Okay? We use the steroid injection. Now, the visco supplementation is used a ton in the knee. And that's basically having WD-40 in there. Those of you that have had Synvisc or all those medications put in the knee, it's a lubricant injection. That's all it is. It's like putting WD-40 in there. And the shoulder does not work. There are guys that have tried it. They're very respectable people that still do it because it should make sense. But when you look at the shoulder diagram I showed you before, that capsule that hangs down, as soon as you put that $700 injections in the shoulder, it collects in the capsule. It does not coat the joint. In the knee, you inject it, and there's no dropping capsule. It coats the joint. But there are very few good outcomes from doing visco supplementation. It's called hyogen. That's that coating of the joint. So I don't do that. Okay? PT, again, I'm harping on this over and over, but if you can do adequate strengthening, sometimes it takes an injection to do that. If you can do adequate strengthening, it helps. You might only be able to do certain things, but it helps. You can work on your shoulder blade. That way your platform is good. That helps. These guys are very good at doing joint mobilization. They're very good at doing strengthening. That helps. But the downside is this. If you have severe arthritis and we send you to therapy and you come back and you're mad, that may be worse. Blame your therapist. Don't blame me. No, just kidding. So your job is to do your strengthening. Okay? If the shoulder gets strong and you're doing very, very well, hooray. If your shoulder doesn't get strong, then that's kind of the next step in that discussion. Now, pre-arthroplasty treatment. So activity modification, you shut things down a little bit, you do a little less, you play pickleball 6 times a week instead of 8 times a week. You do your therapy, you take your NSAID, you use steroid injections. Synvisc is a visco. I don't use that. Arthroscopic debridement. If you're super young, if you're 35 to 40, maybe up to 50, and you've lost motion and you have severe arthritis, sometimes we can go in there and we can clean it out. And you see a very good picture here. This right here is normal articular cartilage. It should be beautiful, white, and smooth. See that? This is exposed bone. So the cartilage coating to the humeral head is 5 to 8 millimeters thick. Not very thick, right? So if you lose this articular cartilage, by definition, that's arthritis, right? And if you have loss of cartilage here and loss of cartilage here, now you got bone on bone. Okay? Some of my most, go ahead.
So what picture did that come from?
That's an arthroscopic picture.
That's
Because sometimes people that have arthritis, sometimes we can go in there and debride that arthritis and release the scar tissue and give them better motion. But I'll tell you with 100% certainty, some of my most unhappy patients have been arthroscopic debridement for arthritis. So unless they have something to go after, like a spur or a bicep tendon that's, that's angry, if you go in there and you debride this articular cartilage, usually we made them worse. Okay? And why? Because it's like having a Teflon coating in your frying pan. If your Teflon coating is dinged, your eggs stick. You say, "Woof, my Teflon coating is," and you go in there and try to sand that Teflon down, your eggs still stick. Same thing. Okay? Nobody likes sticky eggs. Okay? Now, if you have diagnosis of arthritis, and if you have failed conservative measures, and if your significant other is pulling your ear so much saying you got to get fixed, we're now talking about shoulder replacement. Okay? And shoulder replacement, in my mind, comes in 3 different categories, but mostly 2 we'll talk about. Okay? So a shoulder replacement, you can have an anatomic total shoulder arthroplasty. And what that means is we're basically replacing the parts like they're supposed to be. Okay? So what does that mean? We're putting in a metal ball, we're putting in a stem, and we're putting in a socket to recreate your normal anatomy. Okay? Now, a reverse shoulder, which we'll talk about, is we're changing your anatomy. So an anatomic total shoulder versus a reverse total shoulder. Got me? So this is an anatomic shoulder where we're replacing normal anatomy. A reverse total shoulder, we are flipping that head around. I'll show you on model. But just for a second. I love this model because it's a great depiction, right? So a normal anatomic shoulder replacement is this. You have your native humerus, you have your native socket, and they go together just like this. And we're replacing that by taking out your arthritic head, we put in a stem and a head, put in a socket, and it fits together just like that. That's one type of shoulder replacement. We're going to talk about that. Okay? The second type is a reverse. Like all things in orthopedics, it's got to be very simple. We are basically reversing where the ball is to the socket side, and we're reversing where the concave surface is to the humeral side. That's what a reverse is. And we'll talk about the difference in those two. Okay? Go ahead, please.
They're both considered.
They're both considered shoulder replacement, but your major question should be, is it an anatomic shoulder replacement, or we're replacing it normally, or is it a reverse shoulder? And we're going to talk about those, okay? So the other one is hemiarthroplasty. Hemiarthroplasty is a part of a shoulder replacement where we're only doing the humeral stem. And I would tell you that should be very uncommon now, because the new implants we have are so bone sparing. In my mind, there's very, very, very minimal use for a hemiarthroplasty. The reason is, if we do a hemiarthroplasty and I put in a metal head, that metal head will erode into your native bone socket, creating a non-reconstructible problem. We have an issue there. Okay? So I would tell you, just don't think about the hemiarthroplasty. Think about the anatomic total shoulder, and think about the reverse shoulder. We're going to talk about that. Okay? So indications for shoulder replacement in my mind: arthritis, rheumatoid arthritis. Osteonecrosis means that the humeral head has lost its blood supply, collapsed. Okay? If you have trauma, if you've had an injury there and there's bad damage and that's led to arthritis, that's an indication. Proximal humerus fractures and cuff tear arthropathy. We're going to talk about that a little bit, but that's when you have bad arthritis and the rotator cuff is not functioning. Okay? Next. So, first step is, are you a candidate for an anatomic total shoulder? Okay? So, our arthroplasty goals, you say, well, what am I going to get out of this? Well, hopefully, pain relief. Hopefully, we've operated on you because your pain is 8 out of 10, and our goal will be to get you down to a 1 or 2 out of 10. If somebody tells you they can put metal and plastic in your shoulder, and you're not going to have any pain at all, run, because they're probably a magician. Okay? So do not think, go ahead.
So having had bilateral hip replacement, now I need shoulders. But my hips are great.
Awesome. That's fantastic. So people have,
Hoping for shoulders.
well, and there's some people that have no pain at all. But as we counsel you and talk to you, we say, if you have a pain level of 8, right? Hopefully we can get you down to 1 or 2. These shoulders do very, very well. But if I tell you you're going to have a pain level of 2, and you come back in 6 months and say, I feel great, you're happy. If I tell you you're going to have no pain, you have a pain level of 1, then you're pissed off. I don't want to like when you're mad. Okay? Okay. So our goal for arthroplasty is pain relief and to improve your function. Right? So if you have bad arthritis, you've lost joint motion, you've lost strength, and our goal is to improve your function. That means you should be able to do it the way you want to do. If we can do an anatomic shoulder replacement with the implants we have now, you should have very, very limited, limitations on your activity. Okay? The reason is, old style shoulder replacements, they were big giant stems. And we had to take away a lot of pain to do it. Now the newer implants are very, very small, and I'll show you some examples here. So the implants that we use are from Shoulder Innovations. Why? Because they are so small and they preserve the bone. Okay? A new style stem is that. That's all it is. Okay? If your bone's not so great, there's a smaller stem, but our goal is to preserve bone in case we have to go back. Go ahead, please.
For how long will that last?
Forever. No, just kidding. So we hope the old style implants, we're getting good. We're getting 20-year outcome. We expect at least that good because we are now more recreating normal anatomy than putting in a big old giant metal head. So we're much more precise with our preoperative templating to recreate normal anatomy. If we can create normal anatomy, the rotator cuff will function completely normal, relatively normal, and you should get long-term relief. That's the goal. Right.
What kind of work restrictions apply after that surgery?
The main work restrictions here is you can't really do heavy-duty machinery work, right? Running a jackhammer, right? You run a chainsaw all day. Those kind of things, the vibration is not great for the stem. We let people play golf. We let people do, do whatever they want. Why? Because we have hopefully properly soft tissue balance. I mean, your rotator cuff is functioning like it should, and you should be able to do what you want to do. Make sense? Yeah. Okay. Next. Except run a chainsaw. Because that vibration can lead to early loosening of the implant. Okay? And something that's truly new and exciting, and Brandon's back there, he helps me a lot, and Ryan's sitting here. So when we look at your evaluation before surgery, we get a CT scan. The reason we do that is now we can virtually do your surgery. And there's 2 guys in the room that are very good at this, and they help me. And then we can look at the size implant you need. We can see exactly how it fits, how much bone to take out, and we can put that implant exactly where it goes. We can virtually do your surgery before you ever go to sleep. That's a game changer, right? We used to, we do the best we can, we say it looks good, but now going in, we have a fantastic plan knowing exactly where it goes. So when you complain about having a CT scan before, I'm going to tell you, because I can use that and virtually do your surgery before you ever have surgery. Your outcome is going to be better. Okay? So we use CT scan. Now, the skin incision everybody asks about, it's about a 6-centimeter incision on the front part of your arm. It's a muscle splitting approach, not a muscle cutting approach. So we get in there without cutting any muscles, except We have to take down the front part of the rotator cuff to get in the joint. Okay, next.
How long was that incision again?
6 centimeters from here to here. Okay? Now, I love this slide because this shows my progression. When I was a shoulder fellow at Duke, a long time ago, this was a stem we used. Big, giant piece of metal. Big, giant head. And if you look carefully, there's a plastic implant in there. And this patient came back 2 weeks ago. 15-year outcome, no pain, doing fantastic. She came back for her other side, right? And I was shocked by the difference of what we're doing now compared to what I was. Now, these implants are doing very, very well. But in my opinion, we're better at shoulder arthroplasty now because this one's from 3 weeks ago. Look at the difference in this stem size and that stem size. Look at the difference in recreating the normal contour of the humeral head. And the reason we look at that is we've recreated the normal alignment of the shoulder, right? And we've done that through a very small head, a very small implant in a socket part that insets inside the bone instead of doing this. I'm 15 years, she's fantastic, no pain. This is fantastic. But our thought process of the shoulder replacements we do now is a whole different ballgame.
What is the material made of?
Cobalt chrome, titanium, steel, all kinds of stuff. So if you had to have an MRI scan later, you could. Now, it wouldn't show anything in the shoulder, but you could have an MRI scan. So there are dramatic improvements for shoulder replacement now. It's outpatient. Okay, unless you have heart disease or lung disease or something that's just problematic, we're doing them as an outpatient. Our anesthesiologists are very good at doing blocks for pain control. So we all know that shoulders are very painful. We can do a block before surgery. Those blocks can last 24 to 36 hours. You have a chance to get on the pain mess and get on top of it. So we have people that do very, very well. Our physical therapy is very, very different. We're a little more aggressive, and you're getting your range of motion and strength back. Again, it's a very different implant from back when I was a fellow at Duke to what we're doing now. And we don't have 20-year data. We think those outcomes are going to be better. We have sure preserved more bone. I tell you, there was a surgeon here in Richmond before who put a lot of these in. And I spent my first 3 years here 15 years ago taking some of these implants out. They're miserable to get out because of infection and failure and that kind of stuff. But we're preserving bone, so if we have to go back, we have lots to work with. So it's higher expectations, and I think it's a different mindset for shoulder replacement now, as long as your rotator cuff is good. Next. Okay, so if you have shoulder replacement, it can be 3 to 6 months return to normal function. There's a very specific physical therapy pattern we follow. The first 4 to 5 weeks, we have to protect the rotator cuff that we've gone through. Because if you have an anatomic shoulder replacement and your front rotator cuff fails, you failed. So we protect that the first 4 weeks. You stay in a sling, you behave yourself. Okay? So it's passive range of motion through those safe zones. You can type, you can text, you can do stuff for the first 4 weeks, but we tell you sling at all times, and no, you cannot drive. The reason you can't drive is you can't defensive drive. If somebody runs out in front of you, you can't defensive drive. Okay? Next. Stage 2, we're starting to work on range of motion. That's where we work on your shoulder blade and the platform. So those pylons in the sand are strong. We're doing some light exercises. And then phase 3 is we're working on normal strength. That's from 8 to 12 weeks. You can expect, our therapist here can tell you, it can take 6 months up to a year to regain strength. Why? Because you have arthritis. And those muscles have not been working correctly for a long, long time. So do not think in 3 months you got 18-year-old muscle again. It takes a long time to regain the motion. It takes a long time to regain the strength. Okay? That's anatomic shoulder replacement. To have an anatomic shoulder replacement, you have to have a functioning rotator cuff. If you don't, you can't have an anatomic shoulder replacement because it's not going to work. So the next topic is a reverse shoulder replacement. So if you have a rotator cuff tear that has led to superior migration of the humeral head and this space is closed down, your rotator cuff is damaged, your only shoulder replacement option is a reverse shoulder replacement. Next. What does that mean? The pain is secondary to the articular cartilage damage. We've talked about that before. So you have bone on bone. And when you try to raise your arm up, that rotator cuff not functioning very well, that head is going to come out of the joint. So the joint is destabilized. You've lost that center of rotation there. Okay, next. So the goal of the reverse is we're changing the anatomy. Now the ball is on the socket side. The concave surface is on the humeral side, right? And we have changed that center of rotation to here. And the deltoid muscle on the outside is what gives you the ability to raise your arm up. And hopefully you've got some lower rotator cuff muscles that are going to help. But now you're using the deltoid muscle to raise your arm up, not the rotator cuff. Okay? All right, next. So the reverse total shoulder. This is an implant that I use every single Wednesday and Monday. Okay? The ball is on the socket side. The concave surface is on the humeral side. Very small stem, bone preserving stem. And it's a different idea. You know, now our thought about reverse total shoulder, we are trying to recreate a little bit of a normal anatomy so the rotator cuff that's left can function. Okay? And the implant we use, we're talking about anatomic reverse. We're changing your anatomy before, but you still have a very good chance to have fantastic function. Okay? So our thought process for the reverse has changed dramatically. When I was on staff at UNC in 2008, the reverse total shoulder came to the States. And it was from the French. We were so excited about it. It was fantastic. It was going to solve our issues of folks we didn't have a solution for. And we put them in a lot of people. And we found most people did well. There's some people that didn't do well, right? So we moved to doing it more of a salvage procedure. You had to be 75 or older. You had to be the only option. But now with the newer implants, our thought process has changed. We can get very good function. We can give you long longevity of that function with this reverse total shoulder. Okay? Now, the activity post-reverse is different than an anatomic shoulder. Okay? What we know is the thing you give up, you get this motion and you get strength up here, but the thing you give up is your ability to get behind your back. So a lot of women have trouble, fastening their bra on the back, right? If you're somebody who has to get up there, you're going to lose some of that with that reverse. You can get to your back pocket, you can put your belt loop in, but your ability to get way up your back is gone. But you're giving that up. You're giving that up for you're right. Most people have lost that anyway. But you're giving up that function. Okay, next. So physical therapy for reverse is almost exactly the same, except we protect you a little bit longer. We leave you in the sling because, again, the rotator cuff's not great. It's not a contained joint, so it's a little bit slower. You're in the sling. But again, you can use your hands, you can use your wrist, but you can't be doing any kind of crazy stuff. 6 to 12 weeks, we're trying to restore active range of motion. And again, it takes your body 3-6, our physical therapists can tell us better, 3-6 months to a year to learn how to move again, right? Because now the ball and socket's been reversed. We're putting a lot of pressure on your deltoid to do all the work. So it takes a while. Recovery takes a while. Okay, next. Anytime you do reverse shoulder, anytime you do a standard anatomic shoulder, there are complications. Our infection risk is very, very low, knock on wood. Infection risk is less than 1%. We're very precise. If you cannot have any open wounds, you can't have any infected teeth, you can't have a bladder infection. If there's any active infections, you should hold off on a shoulder replacement, right? Because if you have active infection, your chance of infection is higher. Okay, so we hopefully don't have infections going in, and hopefully we use sterile technique, which we always do. The chance of infection is very, very low. Dislocation reverse, it was 10 to 15%, but now with the newer implants, it's usually 5 to 7%, which is much lower. And that just speaks to us. We're trying to recreate normal anatomy, not changing your anatomy. The biggest problem with the reverse is folks who have osteoporosis or not great bone. Sometimes this ball, they see so much force can come loose. Hopefully we've done a very good job in our CT planning, and we're putting that ball in the exact spot that has the best bone. Revision surgery is about 10%. Next. So, this is to answer your question. So, any shoulder surgery you have, whether it's rotator cuff, whether it's total shoulder, there's some key components here. First one is pre-op clearance. You got to be in good health. We're getting ready to put a hurting on you, okay? If you're smoking, That's the one thing that will prevent your rotator cuff from healing. The one, if you're smoking, you ain't healing. So that's as good as that. If you have diabetes and your hemoglobin A1C is above 9, and we do a rotator cuff repair on you, your chance of getting adhesive capsulitis or frozen shoulder is high. So we tell you, shouldn't be smoking, your glucose could be in control, and your BMI. We know the complication rate is higher if your BMI is above 40. Okay? So if your BMI is high, the chance of infection is higher, so we can give you nutritional counseling. Our job is to maximize your medical condition going in. You should stop taking supplements and NSAIDs. Why? Because you bleed more, right? So you got to stop those 5 to 7 days before, okay? You need to think about your surgery. You should set up your house. There are special pillows you can get that keep you propped up in bed with fantastic supports. We tell people to get a recliner, or you can rent a recliner, because sitting up with gravity pulling your arm down, with ice on your shoulder is going to be your most comfortable position, right? So having some ability, either with a special pad or sitting up in a recliner, is going to make your post-operative course for 4 to 6 weeks much better. So you need to think about that, okay? Ice machine, you can use a bag of frozen peas. You can rent or buy an ice machine. You need ice. The other thing is, do not think you can have a rotator cuff repair or a shoulder repair of any type with no help at home. You're going to need help at home, at least for the first couple of days, because you're not going to feel great. You're going to be in your recliner, and you're going to need some help at home. So we call these shoulder coaches, because you're going to need some help, right? You need to get somebody to help you, okay? Pain medicine. Usually our blocks are really, really good, but you can expect to take some type of narcotic pain medicine for 2 or 3 days after. Sometimes we have to extend that a little bit. We know that if you have your surgery and you have a really good block, and you take pain medicine and you control your pain, usually that pain's gone by 2 or 3 days after. If you say, I'm not taking pain medicine, and your block wears off and your pain goes to a 10, you either get an unfree ER visit with an injected pain medicine, or you take a whole bunch, nausea, you're throwing up, terrible. So we tell you, when that block starts wearing off, take that pain medicine every 4 hours for 48 hours, and then try to wean off of it. If we control the pain early on, you're much better off later. Please finish all your home honey-do list projects. Reason for that is if you have shoulder replacement, and then now your significant other is saying, you said you're going to fix that, and you fall off a ladder after a rotator cuff repair, I told you, just remember I told you, you're supposed to finish all your projects. So you should have all that out of your hair. So set up a recliner, get an ice machine, help at home pain medicine, and finish up all your projects. Okay? Post-op surgery. Make sure you have your pain medicine. Talk about that. Nausea medicine, because some people react bad to pain medicine and they'll get a little nauseous. And folks who take pain medicine get constipated. Treat that early. If you take anti-constipation medicine before, it's much less of a problem. Some people are severe, some people aren't. But just think about that as you're taking that pain medicine. You need to start thinking about that constipation medicine, okay? You're in a sling for 4 to 6 weeks. You can't drive. Have transportation. Have people that can help you buy groceries. You got to commit to therapy 100%. I can do my part over and over and over. If you don't commit to therapy, if you're like, I ain't doing that, don't have surgery. If I operate on you and you don't commit to therapy, I've now made you worse. Okay? You can think about the limited lifting so the first 4 weeks you're in a sling, you're not doing very much. The second 4 weeks, 5 pounds at the waist. You can function from waist level to shoulder height with about 5 pounds. That's 6 to 10 weeks. But any type of rotator cuff or shoulder replacement, you can assume 3 to 6 months recovery. Next. Questions, please.
Is the regular shoulder replacement, if you compare it to the reverse and the regular, people tell me the reverse you heal quicker than, and it's just a faster result than the regular.
Are you paying for that advice? I'm asking a question. Are you paying for that advice?
No, well, no, I've talked to friends who've had the reverse.
Is it free advice?
Yeah.
It's worth as much as you pay for it. and the reason for that is this.
Okay.
If you are a candidate for a total shoulder replacement, that means your rotator cuff is good. You will do better long term, 3, 5, 7, 10, 12, 15 years with an anatomic shoulder replacement. It may take you longer to heal. The reason is it takes your rotator cuff longer to heal. You're exactly 100% correct. That healing time from 12 weeks to 16 weeks to 20 weeks is easier for reverse shoulder. But your long-term outcome, 10, 15 years, you'll be happier you got an anatomic shoulder than a reverse. So your friends are exactly right. That recovery is easier for reverse because we don't care about the rotator cuff. But for the anatomic, it's slower because we have to protect that rotator cuff and let it heal to provide you 15 to 20 years of good function.
Do you take that loose from the humerus? Is that how
You have to take the subscap down from the humerus and put it back down. It's the only way to get the shoulder. I saw, go ahead.
Could you clarify, please, for me, the reverse repair, total repair, from an injury or trauma?
Sure.
What time frame do you look for to actually have the surgery? Is there a gate or a
Sure. So,
window?
yeah, so I answer that question two different things. So we do use reverse shoulder for fractures, okay? Because after a fracture of the shoulder, the rotator cuff is usually not so great. So it's common for us to use a reverse total shoulder for fracture management, okay? Now, in a hip fracture, our job is to get in there and fix, not my job, I don't do hips, but our job is to get in there and fix that hip ASAP to get you moving. But for a shoulder fracture, if somebody tells you have to have a shoulder replacement, you can take a deep breath. There's no urgency. So to get the best outcome, if you can have that done in the first 2 weeks or so, usually we can mobilize those fragments around that implant and have you have the best outcome. Okay? But usually what we do, we see in the ER, you get a sling put on you, and we see you, we get a CT scan so we can plan what in the heck you need. We make sure you're medically maximized, make sure your diabetes and everything's under control, and then we go in there and we fix that. If you have a fracture, and you say, well, I'm going to try conservative management, and you give it 6 months, and it heals wonky or out of place, you can still do a reverse at that point. The outcome, the long-term range of motion strength is probably not going to be quite as good, but the reverse we can use at any point during that fracture healing. Does that answer your question? Okay.
Well, what happened is she had rotator surgery, and then she fell down some steps. She had gotten her floor range back, and now
I fell down the steps and tore
destroyed.
everything up.
And they said, we can't do anything with it.
So you're a reverse candidate, right? So that trauma was not a fracture; it was a re-tear, right? And your surgeon probably thought he couldn't go back in there, he or she couldn't go back in there and fix those tendons, which is a pretty good thought. So the only other option for you would be a reverse total shoulder.
Okay. You are given an injection of steroids.
Yeah.
Do you have to wait a certain
Yes,
amount of
that's
time
a
surgery?
fantastic question. So there's some good data out there that says you should wait at least 8 weeks following a cortisone injection, or your infection risk goes up. And other point I'll make there is if you have a rotator cuff tear, there's also good data out there that says if you have a rotator cuff tear and you're trying to just get through the summer because you got projects and you have more than 2 or 3 injections, that affects your long-term healing.
Thank you.
Question back. Hang on just a quick question in the back.
I was told I need a complete shoulder replacement. You and I talked.
Right.
I think you said 3 of the 4 tendons are torn.
That's a reverse.
That's a reverse.
So if
We didn't discuss what type. It's just.
Yep.
And so basically said we're not going to do anything. Just work that shoulder.
Right.
So am I sitting on a waiting time bomb?
Nope.
I'm getting older and older. I don't want to get 9.
So the issue there is if you have a 3 tendon tear, we can maximize your strength of the tendons you have left. We can work on your pylons in the sand, right? And if you fail, if you're having severe pain, you get a reverse. Okay. The only other thing that'd be a ticking time bomb for you would be if next 10 or 15 years you have a heart attack or you have a stroke, and now you medically can't go through that surgery. Okay? But you're taking time off of having 3 tendons torn and not fixable goes away with the reverse. You can have a reverse done at any point as long as you've shown me you failed therapy.
How many times can you do a reverse?
It's a great question. Not many. So the old style reverses, where we put the big ball in there, it was very hard to revise. But the new styles of anatomics and reverses that we're trying to preserve as much bone as we can go back. But every time you go back in there, there's more scar tissue. Every time you go back in there, you can expect less motion and less pain relief.
Have you ever done an anatomical replacement and later on done a reversal?
Absolutely. That's a great comment. And so the implants we use are made to do both. So if you look at these, I'm going to put this microphone down for a second. So if you look at these modular implants, okay, the old school implants, if we had an anatomic, that big giant anatomic stem I showed you, we had to go in there and take that thing out. You're destroying that cortical bone. Now the implants we have a stem that's in there for an anatomic shoulder. We can easily convert that from a normal shoulder replacement using one adapter. Now it becomes a reverse. So we're not destroying the humeral bone to get this implant out. That's a great question. But the old style implants, they're still being used, are non-convertible. The newer implants with this new company, that stem's in there and it's stable and it's in the right spot. You don't have to do anything. It makes my job a lot easier. I go in there, I pop this head off, this goes in there, we put that giant ball in there, away you run. Questions?
I'm glad you clarified about taking the NSAIDs, because if they're doing the onesie-twosies, they take them for about 10 days straight.
Mm-hmm.
How long would I expect to get relief from that, knowing that my next step might have to be an injection? I mean, how many cycles do I?
I tell people give it 3 weeks. If you're taking the injections, if you've gone on it for 7 to 10 days, you've been off of it for a couple of days, and you go back on it for 7 to 10 days, and come off of it and you're still hurting, it's time for an injection. And some people come in saying, I want the injection, I want the medication, I want the ice, my ear's hurting because my spouse is saying you're not sleeping at night. And we can do all that at once.
I'm going to backtrack a little bit.
Please.
What would you do if you developed some scar tissue after having supraspinatus surgery?
I check your sugar, make absolutely sure you didn't have diabetes. That's a common implication. And sometimes we have to go back in there and debride scar tissue to get your motion back. Usually it takes, we let our physical therapist work. Sometimes we put an injection there to try to relieve that scar tissue. But if that fails, sometimes we have to go back in there and relieve.
Which way of removing it? What do you do?
An arthroscopic debridement. So you go in there with a scope, you take this little wand and you remove the scar.
Is there a reason to wait for rotator cuff surgery? I mean, I have some pain, I don't have it at night, I have some weakness.
Depends on the tendon quality, if it's retracted off the bone. Because if you wait on that, it ain't fixable.
Right.
If it's a partially displaced, you can wait as long as you want to wait.
Okay. And you should.
And there's a reason to wait. I mean, if you have summer projects or you have stuff going on, and surgery should always be the last answer, as long as it's not displaced.
But it's gonna, I mean, it's normal wear and tear, so normal wear and tear continues on when, I mean, does it ever totally tear and then you can't do it anymore?
Then yeah, it can. But you're going to see less and less function. So you're going to see over time, well, I have some pain up here. Well, now I can't get up there, and hopefully you're following that along.
Okay.
All right,
So
please.
I haven't been to an ortho yet.
It's a good choice
Okay.
this season.
But my, complaining of shoulder pain,
Mhm.
so my doctor took an x-ray and he said, well, you've got arthritis.
Of the shoulder joint
Uh,
or the AC joint.
So, I don't know.
Okay.
He didn't say.
Depends on where it is.
And but I asked him, because I had a, not a dislocated shoulder, I had a separated.
AC joint, yeah.
Yeah, I separated my
Yeah,
shoulder
yeah.
back 40 years ago.
Mhm.
And I asked him, could it be from that injury? And he said, most likely.
Yeah, so what that means is, hopefully what he's seeing is arthritis where the collarbone meets the acromion. Not a lot you can do for that. You can put an injection in that sometimes. It can give you some relief, but it's not the true, it's not the true shoulder joint.
Okay.
So you're
Yeah,
safe.
I only have pain from movement except
Pressing
back
motion.
here.
Yeah. So if you work on your shoulder blade strength, like we talked about,
Yeah.
it pulls your shoulders back. It pulls some space in that joint. If you're used to sitting like this on the computer and your
Yeah,
posture's not
I do
great,
IT work.
right? You do. So if you sit forward, like the guy on the film, if you sit forward, you're getting compression across the AC joint. You work on your shoulder blade, you work on your pylons in the sand, you pull your shoulder blades back. That can help. Our physical therapy
Yeah,
can
I
help
have
that.
days of work where,
Yeah.
I mean, it just aches.
Look at your posture.
That-
Put a Post-it on your workstation. Sit up straight. And every time you see it, you pull your shoulder blades back.
Okay.
Other questions? Thanks for your attention.
Thank you.
Here's your